Hi everyone, welcome to the Orthopaedics recall of INI set questions. I am Dr. Abbas Ali, your orthopedics teacher here at Marrow. The first thing I want to tell you about the INI set exam and the questions that came in orthopedics were that they were not over the top. They were not extremely different from something that is usually asked in these kinds of exams. But the fact of the matter was that these questions came from the topics that we were familiar with and were heavily tested in the previous exams, but they were modified. And they were modified in a very clinical approach. So a lot of clinical acumen and practical ability to answer these questions were required. To answer the questions that although seemed like come from the topics that you knew, but their presentation was different. So the aim of this session is to basically understand what those topics are and also try to touch on the questions that were there. But the problem with these kind of recall-based questions is that we cannot actually recall the exact specific wordings or the language of the question and the options. So I've tried my best and we have collected this information from a lot of people, but the fact of the matter remains that the aim of this session is to not exactly look at the question and the answer, but to learn parallelly around the concept that was tested in the exam, so that if this concept is tested again in your next exam, you should be ready with it. So let's start with the first question. The first question is, which of the following braces is shown in the given image? So a question like this is a spotter question, where they are showing you the image. Now the problem with this is a very simple question. You know the answer or you don't know the answer. There is no scope of understanding concepts or anything. So let's look at this. What do you know about this? If you have attended the spine module, you would know that this is a Milwaukee brace, right? This is a Milwaukee brace. But let me just tell you this. In the last 1 year, I've noticed a lot of questions coming from the scoliosis topic. So that is why when we were recording the Marrow 5, I've actually discussed a lot more scoliosis in detail, expecting that these kind of questions will show up more in the exam. So let's talk about these braces and what are these other braces and what are their purposes. So this is in front of you, a Milwaukee brace. What does it have? Both of these are your Milwaukee brace. What does it have? It has a pelvic mold. It sits on your pelvis. It has a pelvic mold. It has an anterior bar and 2 posterior bars. Anterior 1 bar and there are 2 posterior bars. Now apart from these bars, there are also these pads. These are known as lateral pads. These are known as lateral pads. Now the purpose of these lateral pads is to compress the primary curve of the scoliosis. So suppose this is the scoliosis and this is the primary curve. So it will compress it. It will compress it. It also has a cervical ring. It also has a cervical ring. So these are the things I want you to remind yourself whenever you're learning Milwaukee brace. Now the other braces that we use for scoliosis are these ones. This is your Boston brace. Okay, it does not have those bars that you see in Milwaukee brace, and you also have a Charleston brace. Right, you also have this Charleston brace where there is one side slightly longer than the other. Okay, so let me tell you what are the uses of these braces so that you should be prepared for it in the next exams. So Milwaukee brace, Boston brace and Charleston brace. Right, use all of them for scoliosis, but there is a problem with Milwaukee brace. I told you there is a cervical ring, I told you there is a pelvic mold, there is an anterior rod, posterior rod, so it's high profile, it's heavy, so patients are not very happy with it. But remember, it gives you the best correction for scoliosis, but most of the times the patients are not very happy with it. So they prefer Boston brace because of its low profile and easy to use, right? But the thing is, it does not give you the best possible results in terms of correction, but it is the most commonly used. Okay, this gives you the best correction. It is the most commonly used. Now the patient has to use both of them for more than 20 hours a day. Right, and that is one disadvantage of these two braces, and that's why some people also prefer Charleston brace, which is worn only during the nights. Only during the nights. The only disadvantage with Charleston brace is it's quite expensive and not affordable to a lot of people. Now, please, when you're talking about scoliosis, I don't want you to forget 2 very important things that were asked in the previous exams. One was the Adams forward bending test, which is a screening test performed in school-going children to pick up scoliosis in order to differentiate between structural and non-structural scoliosis. Non-structural scoliosis is the postural scoliosis, probably some abnormal position that you are sitting in right now. So if a patient has a non-structural scoliosis, that is postural, and he bends forward, the spine becomes normal. And when the patient has a structural scoliosis, whether it's a congenital problem or idiopathic problem, they will have a deformity. And you can learn more about this in our scoliosis or spine module. Another thing I want you to remember and not forget is the Cobb's angle. Right? Cobb's angle is used to measure scoliosis. Now, the other options. There were two more options. One was Taylor brace and the other was Ash brace. And I'll be doing injustice if I don't discuss this. This is the brace, Taylor brace. And this was asked just a few days ago in the FMG screening exam. This is used for vertebral compression fractures in osteoporosis or post-operative when you have performed surgeries on the spine in terms of either disc surgeries or fusion surgeries to relax the spine. So this brace basically helps keep the patient remain in extension so that it does not go into kyphosis. There is one compression here over the abdomen and there is support here at the back. The compression over the abdomen basically increases the abdominal pressure, making it a compact compartment, keeping the spine in support. So Taylor brace used for kyphosis, osteoporotic fractures or post-operative relaxation of the spine. And similarly, there is something known as Ashy brace, which stands for anterior spine hyperextension brace. Okay, anterior spine hyperextension brace. It has these things that will keep your spine in hyperextension, again preventing you from going into kyphosis. Ideal to be used in patients with vertebral compression or osteoporotic fractures of the thoracolumbar spines. Now the second question has two variations. One is, which of the following substances is used for bone formation in patients with non-union? And the second variation that students told me is for non-union, a drug that can improve the chances of union. Right? So essentially it means the same thing. They're asking about a drug that can improve union. The options are calcium phosphate, calcium sulfate, PMMA, and bone morphogenetic proteins. Now, whenever I talk about these non-unions and the treatments of non-union in my modules, I've told you that the best source of bone graft, the best treatment for non-union is autologous bone graft, right? You take this bone graft from the patient's own iliac crest. This is what you're doing here. You take it from the patient's own iliac crest. Now, what are the advantages of this autologous bone graft that you harvest from the iliac crest? I told you it has three very important properties. The first property is osteogenesis. Right? Osteogenesis. What is osteogenesis? When the graft, the piece of graft itself, by virtue of presence of osteoblast in it, grows new bone. Right? It grows new bone on its own. It grows new bone on its own because of the presence of osteoblast. So no drug can actually cause osteogenesis. It has to have osteoblast. So you can actually use stem cells or the patient's own osteoblast to manufacture more bone. The second property of this autologous bone graft that we use is osteoconduction. Now, what is osteoconduction? Basically, this graft, the piece of bone or the graft that you have kept, because of the presence of surface on it, allows the new bone to grow on it. So it acts as a scaffold. It acts as a scaffold or surface for bone growth. Now, we have drugs or we have substances that can act as a scaffold for new bone formation, and those are your calcium sulfate, calcium phosphate, bone cement in the form of polymethyl methacrylate. Okay, so all of these things are osteoconductive. They provide scaffold or surface area for the new bone to grow on. The third important property of autologous bone graft that we harvest from the iliac crest is osteoinduction. Now, this property is very unique because this is a property where it releases certain growth factors. It releases growth factors, is stimulating the host bone to manufacture new bone. So it releases growth factors which basically stimulates the host bone to manufacture new bone. Now we have substances which we have recombinantly manufactured as growth factors that can stimulate the host bone to manufacture new bone, and that is your bone morphogenetic proteins. And that is why the answer here is bone morphogenetic proteins, because bone morphogenetic proteins stimulate the host to manufacture its own new bone. So once you understood these three characteristics about bone graft, you can understand what are the synthetic forms of these things available to either perform osteoinductive or conductive or osteogenetic action. Osteogenetic action is very difficult because unless you have your osteoblast, you cannot make new bone, but conduction and induction is possible. Now look at this diagram. What is this? These are your bricks or chunks of calcium sulfate and phosphate that are available in the market. So whenever we are performing bone graft in places where the space or the requirement is more than the bone graft that we can harvest, we can use these synthetic calcium sulfates and phosphates. And nowadays these are actually coated and impregnated with bone morphogenetic proteins that also induce the host to form new bones. And also a recent advance is that the newer implants that we are using for fracture fixations sometimes also have bone morphogenetic proteins coated on them that can help osteoinductions in fracture healing. Now in the next question, again I have two variations in questions and a slight controversy in the options, so I've kept everything here so that we can discuss. The first variation of the question is, in the given spine straightening surgery, the screws are fixed to which part of the vertebrae? So probably they're talking about scoliosis once again. The second variation is, vertebral fracture has been fixed with a screw rod construct. The screw used is fixed through. So essentially what they're talking about is the screws that you use in spine surgery to either correct them or in forms whenever there is a deformity or to treat fractures. Where will you put the screw or place the screw? The options given were spinous process, lamina, pedicle, facet joint, transverse process. Now I don't know if the image was given or not. Most of the students were saying it was given, some of them were saying it wasn't given, and I don't think it would have made a huge difference, because it would have been a huge task for you to identify what they are trying to show you. Nevertheless, in this image, it's a spine surgery being operated where the patient is prone and the surgeon is approaching the spine from the posterior aspect, and he's making a hole to put the pedicle screw. So the answer here is pedicle, and I will tell you what and how. So this is a typical vertebra that we're going to talk about, and this is the vertebral body, and this is your spinal canal through which the spinal cord passes. This is the spinous process, the transverse processes, and this is the pedicle that we are talking about. This is the pedicle that we are talking about. And this again is the lateral view, the vertebral body, the spinous process, the superior and inferior articular facets, and the transverse process. Now, if you look at the spine, if you put a screw from any place, right, there is a risk that it might enter the spinal canal. If it goes here, it will enter the spinal canal. Anywhere, if you insert it, it might go into the spinal canal, causing neurological deficit. So that is why we have found this conduit that allows the screws to be passed all the way from posterior to anterior without entering the spinal canal. Now, obviously, if you're an untrained surgeon and it's a risk or a complication of the surgery that it might go into the spinal canal, but you have a path. That is the first thing, and that is why we prefer pedicles to put in the screws. The second thing is, if you go back to the spine module, and we've talked about the trauma in the spine, I've told you there is something known as the Dennis 3-column concept of stability. Right, I've talked about this. And I said the spine for stability is divided into the anterior, middle, and the posterior column. And if there are any injuries where 2 or more columns are affected, we will call it an unstable spine. And these are the parts of the anterior column, middle column, and the posterior column. So suppose there is a fracture or an injury and you want to stabilize the spine, you want to put a screw that can actually fix or fuse all the 3 columns together. And the only way you can do that is if you put a pedicle screw and it fuses the posterior, the middle, and the anterior column. Okay? It fuses the posterior, the middle, and the anterior column all together. Okay? So posterior column, middle column, and anterior column. Okay? Now you understood. Now you understood why we put screws in from the pedicle. Again, just for reference and future uncertainty, these are the x-rays that I would like to show you. This is a lateral view. We have put a pedicle screw here into the vertebral body through the pedicle. And by putting these rods, you can basically, if it's a kyphotic vertebrae, say if it were a kyphotic vertebrae, by putting these rods, the interconnecting rods, you can actually extend the spine. If it goes into collapse and kyphosis, you can actually extend the spine, and this is what happens. Okay, you can restore the kyphosis, and this is the construct that we use for spinal fixations and fusions also. Just again working on the principles of your Taylor's brace and Ashley's brace that we just talked about in the previous question. So the answer here is pedicle. Now let's look at this question where it read something like a 10-year-old male child presents with pain around the left knee. On X-ray, there is a lesion at the distal femur. Following are the clinical images. What is the probable diagnosis? Again, a few students told me that there were X-rays provided. Some said there were no gross images, and most of the students said that the specimen image was provided, and this was the specimen image that was provided. The options are giant cell tumor, osteosarcoma, osteoblastoma, chondrosarcoma, and chondroblastoma. Now, if you go and review the bone tumors topic that I have covered, I have told you to approach the MCQs of bone tumor keeping two things in mind. First, the age of the patient, and number two, the location of the lesion in the bone in terms of whether it is epiphyseal, metaphyseal, or diaphyseal. And based on these two important hints, you will be able to answer almost all the MCQs even if they do not give you extra hints. That is the advantage if you look at it from that perspective. Now, simply looking at the age, a 10-year-old child, can it be giant cell tumor? You know that it cannot be, because giant cell tumor occurs after growth plate fusion, somewhere between 20 to 40 years of age. And chondrosarcoma is also something that occurs in elderly population, somewhere between 40 to 50 to 60 years age group, right? Now, osteoblastoma is mostly diaphyseal, so it cannot be found here in the metaphysis. And osteoblastoma, it in itself does not grow so much aggressively as in the image or the picture that is shown here. So we'll just keep that here as something that we are confused about. Chondroblastoma, we know is epiphyseal. And both chondroblastoma and chondrosarcoma, by virtue of presence of cartilage in their name, chondro, right, their gross appearance would be grayish or slightly bluish. Here the image is showing something that is massively grown like this, number one, and number two, it's very fleshy, which is very characteristic for osteosarcoma. Even without looking at the image, based on the age group, that is 10-year-old child, pain around the left knee joint, so it is more distal, somewhere more metaphyseal, I will be likely to go towards osteosarcoma because it is more fleshy, in appearance. But if the same question had talked about somewhere in the middle of the thigh or middle of the leg in terms of, say, diaphysis, and Ewing sarcoma were in the options, I would have jumped on Ewing sarcoma because Ewing sarcoma is much more common in this age group. Okay? Is that clear? That's how I want you to approach these kind of questions. A few more words about osteosarcoma. Osteosarcoma is a bimodal tumor. Please remember that. That is one word. It occurs in the form of primary and secondary. Primary is de novo, occurs in children in the second decade most commonly. Right, occurs in second decade most commonly, right? 10 to 20 years is the age group, and secondary occurs after 40 to 60 years age group. Also remember, osteosarcoma is the most common bone tumor, in children occurring in the second decade. What is the most common bone tumor in children occurring in the first decade? It is Ewing sarcoma. But also there is an MCQ where they ask you, Ewing sarcoma most commonly occurs in which decade? So Ewing sarcoma most commonly occurs in second decade. But the most common bone tumor in first decade is Ewing sarcoma, and the most common bone tumor in the second decade is osteosarcoma. And if they do not give you any kind of a decade and ask you what is the most common bone tumor in children, then you can say osteosarcoma. So please be careful, these three type of MCQs. Another important thing I want to tell you is this secondary osteosarcoma has another etiology, and the most common etiology for this is your Paget's disease. So Paget's disease patients have a high risk of secondary osteosarcoma. Alright, these are the words that I want you to know. Also, not to forget, this is the most radio-resistant tumor known to man, and it is the most common radiation-induced bone tumor. Right? So, and what are the characteristics of osteosarcoma? It has that sun-ray sunburst appearance. And don't forget this triangle. What is this triangle known as? Right, what is this triangle that you see here? What is this triangle? Yes, it is Codman's triangle. And if they ask you what is Codman's tumor, you should mark chondroblastoma. Chondroblastoma is Codman's tumor. Codman's triangle is seen in osteosarcoma. Okay, and then this image, I hope this is etched in your DNA by now. I've shown you this image so many times. This is a lesion that is in the epiphysis and then growing into the metaphysis after growth plate fusion. This is classical giant cell tumor or osteoclastoma, not occurring in children. Not occurring in children. Very rare in children. As far as your exam is concerned, doesn't occur in children. And chondrosarcoma, please remember, it is mostly in the pelvis or proximal femur. And it gives you the characteristic popcorn calcification. No? Popcorn calcification, rings or arc calcification. Okay, so calcification in the cartilage, so you see hazy or lucent background with some amount of calcification here, and then this is your chondrosarcoma. Alright, so I'm sure you got the answer correct, that is osteosarcoma. Now this is a very easy question. Which muscle is not involved in overhead abduction of the arm? Serratus anterior, deltoid, trapezius, pectoralis major. It's mostly an anatomy MCQ. I'm sure most of you have answered this correctly. We know that the answer has to be pectoralis major. But there was a certain section of students who were telling me that deltoid is the one which brings the shoulder up to 90 degrees and not beyond that, right now, sir? So it should be also an answer. That's what they were contesting. Let me just, review everything with you. See, when you're talking about shoulder abduction, from 0 to 15 degrees of shoulder abduction, this is brought about by supraspinatus muscle. And from 15 to 90 degrees, we have deltoid playing the major role. Now, above 90 degrees, for the shoulder to abduct, you need your scapula to also rotate, that is the scapulothoracic movement, and that is brought about by your serratus anterior and trapezius. This is very important. Now all of these are essentially your shoulder abductor. So let me show you how it works. So your shoulder after reaching the 90 degrees has to go more, and if it has to go more, the scapula has to rotate over the thorax, and this rotation of the scapula is brought about by serratus anterior muscle rotating the scapula laterally and anteriorly, and the trapezius muscles, the upper part, the middle part and the lower part, all helping in the rotation of the scapula. It's much better in this image. So it's this cyclical movement that occurs. So serratus anterior pulls it outwards and anteriorly, and upper heads of the trapezius, the middle head and the lower head, all of these help the scapula turn around, giving you your shoulder abduction, right? So the odd man out here is pectoralis, because the function of pectoralis is to adduct the shoulder. So the odd man out here, my friends, has to be pectoralis major, and there is no doubt about it. Now the next question actually builds upon the previous question that we have talked about. It says patient unable to abduct the arm or abduct the upper limb following a fall. The root value of the involved nerve likely is. Now the abductors of the shoulder we know are supraspinatus, but mostly it's deltoid because it brings from 15 to 90 degrees, and then you have your serratus anterior and trapezius helping beyond the 90 degrees angle, that is overhead abduction. Now we know that deltoid is the principal muscle that they're talking about here, and deltoid we know is supplied by axillary nerve. We know it is supplied by axillary nerve, but axillary nerve is not in the options. You have C5, C6, C4 and C7. So let's look at this. This is your axillary nerve supplying deltoid, which helps in shoulder abduction, but axillary nerve is not in the options. For that you have to remind yourself about the root value of axillary nerve. See, the axillary nerve comes from the brachial plexus, but brachial plexus is formed by all these nerve roots, or the spinal nerve roots, C5, C6, C7, C8 and T1. So C5, C6 participate and make axillary nerve. So axillary nerve root value is C5, C6. So the answer here has to be C5. And because of the injury of the C5, the patient is unable to abduct the shoulder. So remember, it's the spinal nerve that comes and becomes a brachial plexus. So brachial plexus or these peripheral nerves in the limbs are essentially conduits of the spinal nerve. So there can be a peripheral nerve that can have multiple spinal nerve parts in it. Right? For example, if I say ulnar nerve will have C8, C7, C8 and T1. If I talk about radial nerve and median nerve have all the spinal nerves of the spinal cord participating in becoming the peripheral nerve. So brachial plexus or peripheral nerve, these are conduits of your spinal nerve. So that's how I want you to understand, and don't get confused between spinal nerves and peripheral nerves. Now let's look at this next question, and again students have given me two variations of this question. One is the multiple correct question, the other is single best answer wala. So we'll discuss both of them. Here is, which of the following tests are not commonly used in osteoporosis? Options are DEXA scan, bone scan, quantitative CT scan, chemical analysis, X-ray, and these are the options that you have to choose from. And the other version of this is the investigation of choice for diagnosis of osteoporosis. And I think it's quite easy, all of you know this. You have to do a bone mineral density scan, and the investigation of choice is DEXA scan. So there is no controversy. If it were a single best answer question, all of you know it is DEXA scan. But the problem is this. So DEXA scan, bone scan, quantitative CT, chemical analysis, X-ray. And the options were A, B, C, A and B, B, C, D, A, C, D, E. Right? So we know that the investigation of choice is DEXA scan. So there is no controversy there. So any option that is excluding A cannot be the answer. So this has to be the answer. The answer has to be BCD, where it's bone scan, quantitative CT and chemical analysis. But let's just dive into this and understand a little more what the examiner wanted to basically test with this question. Okay. So what are the investigations that you do in osteoporosis? See, whenever a patient comes to you, what is the complaint of the patient when they come to you with osteoporosis? They come to you, the most common complaint is backache. Right? They come to you with backache. And when a patient comes to you with backache, you sitting in the OPD, imagine what is the first thing that you will advise to be done. Do you immediately go for DEXA scan? Do you immediately go for quantitative CT scan? No. The first thing you would do usually is get an X-ray done. You'll get an X-ray done. The problem with osteoporosis is that X-ray findings will only be visible if the bone density has been decreased by more than 30%. And that takes quite a lot of time. So it doesn't pick up the problems in the bone early on. So X-rays do not give you this quantitative analysis of the bone early on in the disease spectrum. So then we came up with something known as quantitative CT scan. Now this helped us pick up the disease early on, but the only challenge was it was expensive, extremely expensive. Number one, and the patient was exposed to so much radiation because it was a CT scan, which was unwarranted. So then we started thinking about this. We started thinking about the single photon emission absorptiometry. Right, we started thinking about this. The problem was that it was highly focused, and you could only measure the density, or the quantitative analysis was done only for a particular part of the bone and a particular part of the body, and it didn't give us a generalized idea. So then we came back to the bone mineral density analysis, which is quantitative analysis but with X-ray yet again, and we call it DEXA. It is dual energy X-ray absorptiometry, and that is what is recommended by WHO to assess the bone mineral density. And you know the T scores and the Z scores and whatnot basically. So nevertheless, one very important point I want you to take away from this is that what is the role of chemical analysis? Chemical analysis is nothing but your blood test, measuring your calcium, phosphate, alkaline phosphatase. See, whenever a patient comes to you with a bony pathology or pathology in the bone, you would want to assess these findings so that we should understand whether there is a disease process going on in the bones, whether there is excessive bone formation or bone breakdown, as in terms of osteomalacia, rickets, or hyperparathyroidism. The thing here is that in osteoporosis, we know that all these findings are absolutely normal. So the question is, does chemical analysis help you diagnose osteoporosis? Of course it does, because unless the lab parameters are not normal, you will not be so confident in saying it's osteoporosis. If it's an elevated alkaline phosphatase, an extremely high level of alkaline phosphatase with bone pains, it could be Paget's disease also, because it also presents in elderly. So chemical analysis is important, which helps you diagnose osteoporosis once you know that the labs are absolutely normal. Are you following what I'm trying to tell you? I'm trying to tell you is a clinical scenario. When a patient comes to you with back pain, an elderly patient, the first thing that you usually do is get an X-ray done. And you also do the lab analysis to assess if there is any serum elevations of either alkaline phosphatase or not. Once the X-ray shows you nothing and the patient still complains of pain and the labs are normal, then based on the age of the patient, which is a typical age of an osteoporotic postmenopausal female of say 50, 60, 65, then you would want to confirm the bone density with the help of a DEXA scan. Are you following? I honestly don't care how the question was presented to you as long as these concepts are clear in your mind. So please remember, osteoporosis is a quantitative problem, not a qualitative problem. The bone is absolutely normal. It's just that it is less in quantity. That is why the labs are absolutely normal. And the last thing I want you to remember is, when do you perform screening for osteoporosis? With the help of DEXA scan. With the help of DEXA scan. When a woman is 65 or older, again this was a previous AIMS question, and if a man is 70 or older. And if you want to memorize all these other indications of screening, please be my guest. Now the next question that we're going to discuss is again in the theme of osteoporosis, which looks like a common theme that has been seen in all the exams. So osteoporosis and scoliosis are very important topics for your exams. Anyways, so among the following drugs, which promotes bone formation? Bisphosphonates, teriparatide, calcitonin, and raloxifene. Now, this question has been discussed by Dr. Ranjan Kumar as well in the Pharmacology INI set review, and he will be talking about the pharmacological concept behind these drugs. But let me give you the clinical practice, what we do in the management of osteoporosis here. See, she's asking you which promotes bone formation. So basically, the osteoporotic medications are divided into three classes. A class where the bone resorption is inhibited. Another class is where bone formation is stimulated. And there is a third class which actually does both the things. It inhibits the bone resorption and increases bone formation. So based on that knowledge, you'll be able to answer this question. So let me just give you the first line drugs in the management of osteoporosis and what I do in my daily clinical practice. See, the drug of choice in osteoporosis, irrespective of anything, whether they say it's postmenopausal female, this female, that female, elderly male, doesn't matter. The drug of choice is bisphosphonates. Okay? It's bisphosphonate. So they inhibit osteoclast. So if you inhibit osteoclast, you are decreasing bone resorption. So you fall into the category of decreasing bone resorption. So the aim here is to either decrease bone resorption or increase bone formation to maintain the quantity of the bone. That's what I told you, right? Decrease the bone resorption or increase the bone formation, or do both if you can. So bisphosphonates, by virtue of inhibiting osteoclast, decrease bone resorption. I want you to remember three drugs here: risedronate, ibandronate, and zolendronate. I use any one of these three. The thing I want you to remember is the dosing. Risedronate is once a week dose, this is once a month dose, and this is once a year dose. Alright. Now with this bisphosphonate, you need to add supplements. Be careful. I said supplements. I did not say the drug of choice. What are the supplements that you can add to increase bone formation or decrease a bone resorption? The supplements that you add is calcium, vitamin D, vitamin K. Now, if you do not add these supplements, will the treatment still suffice? Yes, it will still suffice because this is the drug of choice. But these are supplements that are added to help the patient synthesize bone formation also. Now, most of the patients who have osteoporosis come to you with lower backache. Now, osteoporotic backache is helped a lot with calcitonin nasal sprays. These calcitonin nasal sprays control this backache in osteoporosis. And they are acquired from two sources. One is salmon fish, the other is porcine. We prefer salmon fish origin because it gives you better results. Okay, these are the things I want you to remember. These are the things that I want you to remember. Now, the challenge here is that if you give bisphosphonates for a long duration, there is a complication, and that complication is your typical subtrochanteric fractures. So, this will be a patient who's consumed medication to prevent fractures in osteoporosis, yet is presenting to you with a fracture. This is because of the long-term action of bisphosphonates. See, bisphosphonates inhibit osteoclastic activity. So there is osteoblastic activity but no clastic activity. Now we remember from our basics that bone strength is derived from both blasts and clasts. Here clasts are not functioning but blast is functioning, so the bone strength has been disturbed. And because of that, there is this fracture. This occurs subtrochanteric region in the lateral cortices, not to be confused with pseudo fracture or milkman's or loser's fracture, which occur on the medial cortex. Okay, you can review all of this in metabolic bone diseases videos that I have discussed. But the point I'm trying to make here is that whenever you give patients bisphosphonates, you need to stop them after a particular duration, which we call as a window period, and then you can start again in order to prevent these fractures. So you need to withhold the drugs for a 6 months gap every 2.5 years. So in that window period, what are the drugs that you can give? There is a second line drugs or the other drugs that you can offer the patient. You can give selective estrogen receptor modulators like raloxifene, or if the patient has postmenopausal features and symptoms, you can give hormone replacement therapy. There are two new drugs that you can remember. One is denosumab, the other is teriparatide. Denosumab, teriparatide. Denosumab, if you recall, how does it function? How does denosumab function? It inhibits the rank ligand. And what was rank ligand used for? Rank ligand was released by osteoblasts to activate osteoclasts. By inhibiting this ligand, you're basically not allowing the osteoclast activation, which means denosumab also suppresses bone resorption. Same as raloxifene and hormone replacement therapy, they also decrease bone resorption. I'll just summarize everything later. Just follow me. What is teriparatide? So teriparatide is a synthetic form of parathyroid hormone. Now, how does it help? Parathyroid hormone activates osteoblast, releases rank ligand, activates osteoclast, resorbs bone. But teriparatide also activates osteoblast, but at a subliminal level, at a submaximal level, where it does not release rank ligand, but performs the activity of osteoblast, that is synthesize more bone. So this is a drug that increases bone formation by virtue of activating osteoblast only till they can synthesize more bone. Right? ठीक है? Clear है? Now, a newer drug is romosozumab, which is a sclerostin inhibitor. Sclerostin. What is the function of sclerostin? The function of sclerostin is to inhibit osteoblastic activity. So, sclerostin inhibits osteoblasts. So, if you have a drug that can inhibit the inhibitor, what are you achieving? You are increasing the bone formation. You are increasing the bone formation. Okay. So let me just summarize everything here so that your life becomes easy and you'll thank me later. Just look at this slide, everything is here. The drugs that decrease bone resorption are bisphosphonate, meaning they suppress osteoclast. Denosumab, suppress rank ligand, suppressed osteoclast. SERM and hormone replacement therapy, all of them suppress osteoclastic activity. Drugs that increase bone formation means increase the activity of osteoblast. Teriparatide. Another newer version is abaloparatide, romosozumab, which is a sclerostin inhibitor, and sclerostin inhibits osteoblast. So you are inhibiting the inhibitor, thereby increasing the activity of osteoblast. And finally, strontium ranulate, the wonder drug that does the both, decrease bone resorption and increase bone formation. But unfortunately, we do not use this anymore. The manufacturer himself has withdrawn the drug from the market. The supplements that we use are calcium, vitamin D, vitamin K, and calcitonin for pain. Right, so if you review this table a few times, I'm sure you will be able to answer all the questions that are asked in osteoporosis. The take-home message here is osteoporosis and scoliosis are now the new favorites in every exam. And if you go to these exams without reading these two topics, you're making a huge mistake. Now, in conclusion, what do I want to add? I just want to say that there were a lot of image-based questions in INI set, and this is not unique now. It has become a trend. So you should be aware of all the images that you learn, and whenever you read a topic or a theory aspect of something, make sure that you correlate with the images. And these are mostly your standard images that are seen in your standard textbooks. You don't have to keep searching new places or buy new image banks or something like this. Another important trend that I'm noticing is that there are no direct repeats anymore, because a few months ago when they asked about scoliosis, they were talking about congenital scoliosis. Now they're talking about Milwaukee brace. Then they will talk about the Cobb's angle. Then they sometimes talk about the pedicle screw fixations. What I'm trying to tell you is that direct repeats are out of fashion and everything is now the topic. So read the topic, understand the topic, and have a practical approach to it. What will I be doing if the patient presents to me in the OPD? The topics are repeated, but not the questions. I'm sure I've helped you answer the questions and the queries that you had. If you have any more queries, you can find me everywhere. I'm everywhere on all social media platforms. You can find me on Facebook, Instagram. I go by the name @TheBoneTeacher. You can find me on YouTube. My YouTube videos are there. You can watch it if you want to. But this is what I want to tell you. Ever since the NEET PG has been postponed, I'm actually a bit disappointed for two reasons. First reason is that it leaves you in a place where you do not have an end goal. You do not have an end goal, so the momentum with which you are coming towards the end of the year, moving into January, is lost. The second reason I'm disappointed is that I've been following a lot of good students, which I call my turtles. I've been following them very closely and I've been seeing their progress that was happening over the months. And now because of this delay or uncertainty, they have actually started to relax. And this is what worries me. The moment they start to relax, there are this new group of people who have found this hope, this chance to actually crack the exam, move in, and they will overcome them. So I'm unhappy for them and happy for this new class of students. So I want to talk to both of you right now. The class of students who have been preparing so well and so hard, do not give up. Keep your momentum. Keep on going forwards, because this is what is going to matter. Every time you have seen this all throughout your years, most of the students, there are only few students who study throughout the year, but most of the students study towards the end. And these are the students that will form the top 5,000 ranks. So you have to be among the students who study in the end. It doesn't matter when you started, it doesn't matter how you started, unless you're the student who's studying in the end, you're not in the cutoff. And for the people who are starting now, this is a gift from God. Utilize it, exploit it, jump on it, and do the high yield topics, do the Q bank as many times as possible, and honestly, sincerely attempt grand tests, looking for the weak areas in your preparation and improve on it. There is no shame in getting a low score. There is no such thing as feeling bad. There is no such thing as a wrong answer and why. This is the time to learn. Quickly learn the things that you need to crack the exam and go to the exam as if it's your best attempt. Trust me, now that the exam has been postponed, both of you have equal opportunity to crack it. I wish you guys all the best. I will see you on the other side. Bye-bye.